Yep.
Yes.
All right,
So
great.
we're recording now, doctor. It's all yours.
Perfect. Thank you. Well, nice to meet everybody. As I said earlier, my name is Justin Houman. I'm a urologist and a men's health specialist here in Los Angeles, California. I practice out of Tower Urology at Cedars-Sinai. And the purpose of my talk here today is just to talk about some important men's health topics. This is important for all types of men, and I hope this answers some questions that you guys may have, and more importantly, create some kind of discussion in terms of ways in which you could optimize your life, quality of life, sexual quality of life going forward. So without further ado, just a little bit about myself. So I did my residency here at Cedars-Sinai. After that, I did complete a fellowship in men's health and male reproductive medicine and microsurgery at UCLA. I stayed there, then I came over to Tower Urology here at Cedars-Sinai, doing the same thing, urology as well as men's health topics. So why men's health, right? So the question is, why is men's health so important? So this is, it's a question I love when people ask this, because as you can see here, men die at high rates from 9 of the top 10 leading causes of death. That being said, a lot of these are preventable diseases, right? Things such as high cholesterol, hypertension, diabetes, the types of things that really can be prevented when you're seeing, or if you're seeing and proactive in seeing a primary care physician. So most men, I'm not excluded from that. We try to tough it out. There's no point in seeing a doctor if you're not having problems. Most of the times a male sees this doctor for the first time at the age of 50 or 60. By the time they get to that point, diabetes, high cholesterol, hypertension, these kinds of things have caused a lot of issues on all the organs in their body, and it creates a lot of problems down the road. And then finally, when you think about men, about 100 years ago, men are living at 6 years less nowadays than they did then, which is a big deal. We should be, you would think that we continue to live older and live longer, but that's not the case. And then we're 80% less likely to seek care than women. So today's talk, we're going to talk about a few things, 4 things. Number 1, low testosterone. Number 2, erectile dysfunction. Number 3, Peyronie's disease. And then we're going to finish the talk with something about urinary incontinence. And some of these topics you guys may know about, but I'm hoping everyone learned something from this. So testosterone, right? We all know what it is. It's the male hormone. It's meant to optimize life. And it's meant to optimize fertility. Not optimize fertility, optimize quality of life, give us energy, give us all the things that we need in order to be a man. So what are signs of low testosterone? And some of these signs, we've all experienced at some point: low sex drive, fatigue, loss of lean muscle mass, erectile dysfunction, depression, poor memory, not sleeping the way you used to. As you can see, it's really important to all aspects of our life. It really affects every organ system, especially our mood. Now, we do know there's a lot of things that cause low testosterone. One of them being just the natural declining in age. The testicles, which produce testosterone, are no different than your heart, your brain, your kidneys. As you age, it just doesn't function the way it used to, right? As a result of that, your testosterone levels decrease. We know this, right? We know this. And typically that starts at the age of 40, about a 1 to 3% decline per year starting at the age of 40. Now, what are the risk factors for low T, right? So in addition to aging, there's certain things, that lifestyle factors that do cause low testosterone. One of those being obesity. Men who are obese, unhealthy, overweight, they're 2.5 times, they're more likely to be hypogonadal or have low testosterone. Men with diabetes are 2 times more likely to have low testosterone. Men with high blood pressure are 1.8 times more likely to have low testosterone. So these are the lifestyle factors. These are the things that we could change as men, limit and decrease the chances and decrease the risk associated with having low testosterone levels. Now, when it comes to testosterone, there's a wide range, right? We always say there's a wide range. So in the scientific community, we say anything between 300 and 1100 is normal. It's a huge range, right? When you think about it, it's a massive range. But we do know that less than 300 is low. Now, as important as this number is, this is what I always say, the number is important, but it's the symptoms that are even more important, right? So it's okay if, my testosterone requirement is different than each one of your testosterone requirements. So I may require testosterone of 400 in order for me to feel good, whereas somebody else may require a testosterone level of 600. So as much as this number gives us some sense of what low is and what high is, It's the symptoms that patients are experiencing that we really want to treat. So it's those symptoms that I listed earlier. If you're experiencing any of those, it is important to seek some sort of medical or consultation, because there's things we could do for it. So why do testosterone levels decrease? Like I talked about, normal aging, weight gain, obesity, poor sleep, stress, and the lifestyle factors we discussed. So, there's a huge controversy when it came to testosterone in the 90s, right? Testosterone came out, and there was one study, the first study that was published on testosterone showed, or it said, that men who are taking testosterone are at increased risk of stroke and heart attacks. Now, that's been completely disproven. Well, first of all, that study was done very poorly. If you look at the data in that study, there was women in that study, in that sample size. There was a lot of flaws to that study, but they still published it. Since then, there's been about 18 other publications that have basically essentially disproven that and have shown testosterone is actually great for men. Reason being is this is a very, very important study. So if you look at men, if you look at a 65-year-old guy who has normal testosterone levels, compare him to the same guy, 65-year-old guy who has low testosterone levels, what you're going to find is the guy who has normal testosterone levels, this is what this graph shows, the guy with normal testosterone levels, his survival, his cumulative survival in terms of overall survival is higher than the guy who has low testosterone. Why? Testosterone is so important for a lot of things, bodily functions, right? For our body to function in terms of organ function, number one. Number two, it gives us the vitality, it gives us the energy to go out there, to exercise, to eat right, to socialize. When you're doing all those things, you feel more fit, there's less chance of anxiety, less chance of depression. All these things improve your quality of life, and in doing so, increase your overall survival. So testosterone is incredibly important. We do know testosterone is incredibly important. And the key here is, if you have low testosterone, my goal isn't to get you to a bodybuilder's testosterone level where there are risks, there are side effects associated with that. It's just to get you to that normal range where where your body, your normal testosterone requirement for your age. So in the 500 to 700 range. Consequences of low testosterone, like I said, if you do have low testosterone, you are at increased risk of heart disease. If you have low testosterone, you're at increased risk of diabetes. And if you have low testosterone, you're at increased risk of osteoporosis. So this is just a few of the organ systems that it does affect. And how do you diagnose it? Like I said, the blood test gives us the quantitative number, but the symptoms are more important. You tell me, hey, I have these particular symptoms of fatigue. I'm not sleeping right. I'm not exercising the way I used to. My erections aren't great. My libido is poor. I have depression. All of these things. If you say those symptoms, we check your testosterone and see if those two correlate, and we could fix it. We could definitely fix it. So so some guys will come in and say, hey, listen, I do have low T, but I don't want to necessarily be on a, I do have low T, but I do not want to be on testosterone replacement therapy. What do I do? So like we talked about when we said obesity, you have a 2.5 times increased risk of having low T as a result of obesity. If you lose, this was an interesting study. If you lose 10 pounds of weight, you have 10% of your weight, you have an 85% increase in your testosterone. If you lose 15%, your testosterone levels go up 230 points, which is pretty incredible. It just shows you the effect of what lifestyle does to our testosterone levels. And the other thing you look at sleep apnea, right? A lot of patients have sleep apnea, they get interrupted sleep. Our testosterone levels peak in the morning, right? Because we're producing, or our bodies are getting cleaning themselves out, essentially resetting at night. So guys who have low T, or guys who have sleep apnea, they're when it's treated, your testosterone levels go up about 100 units, 100 points. Now, that's the lifestyle things, or those are the natural ways in which to increase it. Now, let's say that those don't work, and you want to start on some form of testosterone replacement therapy. These days, we have everything, right? We have a ton of options for all different comers. If a guy, basically, it's all about frequency. If you want to do it daily, the way to break it down is you could do it either daily, you could do it weekly, or you could do it every 3 months, right? That's the way you break down testosterone. So there's daily gels, there's daily nasal sprays, there's an daily oral therapy now. There's weekly injections. There's patients who don't like the injections, so there's an automated auto injector that goes against the skin that works great. And then there's testosterone pellets that are placed under the skin that last for 3 months. So tons of different options. So there's no with what we have now, there's very few patients who are averse to any of these. Like I discussed, your options are either daily, weekly, or quarterly. Now, this is a very common question. Patients say, "Hey, listen, I have low T. I have prostate cancer. I have a history of prostate cancer. I'm worried about getting prostate cancer, and I have low T. What are the risks there?" So, historically, right, the historical basis to this thing was we've always known that prostate cancer is testosterone dependent. There's a correlation between increasing testosterone levels and increasing PSA levels, right? We knew that many years ago, many decades ago. Now we know something a little bit different, which is this, and this is very important. If you look at these graphs, it shows young men and old men, the relationship between testosterone levels and PSA. So if you look here, as the testosterone levels on the bottom here on both graphs, it's the weekly testosterone dose. On the left side, it's your testosterone levels, and finally, excuse me, on the left side of this graph, on the left graph, it's your testosterone levels in your bloodstream. And then here you see your serum PSA. That's your blood PSA. As your testosterone levels increase, your PSA does not go up. You see how this red bar stays the same? It both in young men and old men. Why, right? This is incredible, right? This completely changed our treatment plan. Why? Why is it this way? It's because there's something called the saturation model. So we know that as testosterone increases, and PSA increases. However, that only goes to a testosterone level of 250. So if you have a testosterone level of 500 and a PSA of 4, if we increase your testosterone level to 1,000, your PSA will not increase, or it shouldn't increase significantly, right? That's the key here. Why? Because those prostate receptors, testosterone receptors, are saturated above 200 to 250. Sometimes we say 150 to 200. Anything above 150 to 200 testosterone level, your PSA should not increase. So this is very important. This completely changed the way we treat patients. Very important, very useful for us. That's the breakdown for testosterone. If you have any questions, feel free to put it in the chat. I'm happy to answer them towards the end. Now we'll delve deep into erectile dysfunction here, which is incredibly common. One of the most common reasons why patients come to a urologist. When it comes to ED, erectile dysfunction, I'm sure, it's, like I said, it's incredibly common. 40% of men at the age of 40, 50 at the age of 50, and onwards. So 80% of men at the age of 80 have some form of erectile dysfunction. 40 years ago, we didn't have much for you. Now we have a ton of options for you. The erectile process is the things to remember here in order to have an erection. You need good blood flow in. You have to limit the blood flow out, and then you have to have a good nervous system to engage and allow those blood vessels to dilate for everything to come in. So if there's any issues at any point in that process, you could have some form of erectile dysfunction. Now, erectile dysfunction for young guys, it's if you think about it, the blood vessel that goes to the penis is relatively small. If that gets calcified, either due to elevated cholesterol levels, diabetes, or even hypertension, that usually is the first sign of some form of heart disease. So it's always important to be aware of that. As I mentioned, you need good blood. So these are the things you need for erectile dysfunction. Really, it's 4 key things. You need good nerves, a good nervous system. You need blood vessels carrying the blood into the penis. You need good hormone levels, like we talked about earlier, with low testosterone, the low testosterone being it could potentially cause erectile dysfunction. And then finally, you have to be in a good psychological state of mind, trying to minimize your anxiety, trying to minimize your depression, those types of things. Now, when it comes to erectile dysfunction, as I mentioned, the three main physical causes are vascular disease, diabetes, as well as medications. And if you think about the other things that could potentially cause it, prostate cancer treatment's a huge one, whether it's radiation or chemotherapy, radiation or surgery. That definitely is a cause of erectile dysfunction. This kind of just goes over some of the data points regarding erectile dysfunction in terms of how common it is. 1 in 2 men with diabetes have some form of erectile dysfunction. So it's incredibly common. And the things you could do to minimize it, this is what we always say. This is just for good life, right? Minimize your alcohol intake, get a good night rest, reduce stress, eat right, and exercise regularly. And so the treatment pyramid, like I said, tons of options out there. I promise you, right? If you come in, you have some form of erectile dysfunction, I promise you we'll give you a good, strong erection some way, somehow. It all depends on how aggressive you want to be in terms of your treatment. We have plenty of options. So we'll start here. As As you work up the pyramid, it becomes more effective. However, it does become more invasive as a result of that. So at the bottom of the pyramid, everyone starts here. It's the oral therapies, the Viagra's, the Cialis. This works for about 70 to 80% of men. Incredibly, this changed the way we treat patients in a lot of ways. Like I said, it does work. It does work for a bulk of men. However, it's not for everybody. Some side effects associated with nasal congestion, lower back pain. They get some heartburn as well. But for the most part, this does a great job. Now, we all know those. However, over the course of the last few decades, we figured out some other things, such as urethral suppositories and gels, whereas Cialis and Viagra act systemically, right? They act in your whole, you take it as an oral pill, so it goes throughout your body. This is essentially that same thing, but in your urethra. So you put the gel in your urethra, it gets absorbed by the erectile bodies of the penis. They engorge, gives you a good strong erection, and then you could go about your business. This gel is amazing. A lot of guys love it. They swear by it. They say it works great. Some guys experience a little bit of pain initially, but with more and more use, they do great on this. This works for about 60% of men. For 60% of men who have failed the oral therapies. Next one, the next treatment for erectile dysfunction. This is intracavernal injection therapy. So if you look at this image here, as you can see, think of it as an insulin syringe directly injecting an erectogenic agent into the erectile bodies of the penis. This works amazing, right? This is really, it works for most guys, at least for a short period of time. However, with more use of this, it could potentially cause a little bit of fibrosis in the penis. And over the course of 10, 15, 20 years, it may not function the way it used to, which may require further therapies, such as our gold standard here, which is an inflatable penile prosthesis. So if you remember the Reebok shoes in the 90s, pump, 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 this is something similar where there's a pump in the scrotum. It's all internalized. There's two inflatable cylinders in the penis, as you can see from this image, a reservoir that goes in your lower abdomen, and a pump that goes in the scrotum. So anytime someone wants to have an erection, they pump up the device in the scrotum, and the fluid from the reservoir will go into the cylinders and give you a good strong erection. Because the nerves of the penis all ride on the top, there's no this doesn't impact your nerve function, doesn't impact your sensation, pleasure, or orgasm. It's all the same. So this is very well tolerated. Guys love it. And the other good thing about this is over the course of a few years, the more you pump it and the harder you pump it, your penis does grow in length and in girth as a result of this. The length, it grows about 1.5 centimeters over the course of a few years, but the girth is definitely noticeable. The more, like I said, the more you pump it up, it's like any other balloon. It stretches, and it gets a good girth. So that's the inflatable penile prosthesis. And now this is some of our newer therapies, shockwave therapy. This is essentially high energy sound waves that stimulate the growth of blood vessels in the penis. So what's an erection? An erection is blood vessels, right? It's blood engorgement in the penis. So how do you stimulate? What's a great way of doing it is by stimulating new blood vessel growth. So how do you do that? Shockwave therapy. So we found out as a urologic community many years ago, we still do. We treat kidney stones with shockwave therapy. And what we found was sometimes we go in there afterwards and have to take the kidney out. And if you look at that kidney of a patient who's had numerous shockwave therapy treatments, you look at that kidney, it was so vascularized. There was a ton of blood vessels. So we thought to ourselves, what's going on here? So then we did the basic science and we found that shockwave therapy, at least these high energy sound waves, stimulate new blood vessel growth. And again, in doing so, it could help address erectile dysfunction. So we've done studies on rats, and having done biopsies of rat penises before and after shockwave therapy. Obviously afterwards, there's plenty of good new blood vessel growth. Now we're doing studies on humans, clinical studies, and both anecdotally and clinically, we found that this is great. Shockwave therapy is actually amazing. Currently, it is not covered by insurance. So depending on where you are, it does cost cash, does out-of-pocket expense, but it does work. It definitely does work, and it helps a lot of patients. It's also being used in other forms of therapy for patients, plantar fasciitis, essentially bringing new blood vessel growth to these areas, Achilles tendonitis, and even for patients who have heart attacks. They've done this in order to stimulate new blood vessel growth and minimize the risk of future cardiac events. Finally, this is platelet-rich plasma. As you remember, many athletes are doing this into their joints, so we're no different. We do it in the penis. It works great. It works great because what does it do? It basically minimizes fibrosis, minimizes inflammation, and in doing so, creates a more healthy environment for regeneration and new blood vessel growth. So these two forms, shockwave therapy and the P-shot, these are more of a regenerative therapy for erectile function. There you go, stimulates new blood vessel growth with growth factors. So moving on, we'll talk about also Peyronie's disease, which is this is the third topic we'll be talking about. And this, I don't know if anybody really knows about Peyronie's disease, but it's becoming a lot more common. There's a lot of advertisements out there now regarding, I don't know, on ESPN regarding Peyronie's disease. It's about 10 to 15% of guys experience some form of Peyronie's. So what is Peyronie's disease? It's basically curvature of the penis, right? Why do guys get Peyronie's disease? It's a great question, right? And we're still trying to figure that out, but we do know there's two main risk factors for Peyronie's disease. Number one, genetics, and number two, trauma. So from a genetic standpoint, what it is guys of Northern European ancestry, specifically the Viking ancestry, having any Viking lineage in them, they're predisposed to having this. At the age of 50, 60, 70, for whatever reason, they'll develop plaques on their penis. So what is the plaque like? So think of the plaque as a piece of duct tape on a balloon. Let's say you put a piece of duct tape on a balloon. When you blow up that balloon, that area with the duct tape is not going to inflate. So what does that do? It creates a curve angling towards that side of the plaque, right? Now, it's associated with a couple other things, Dupuytren's contractures. So some guys will have plaques on their hands, on the tendons of their hands as a result of this. This is something like John Elway has, actually. He had Dupuytren's contractures. So 10 years ago, we didn't have anything for this, but now we figured out what we can do for this. So actually, I'm sorry, before I get into that, so I said the genetics was the first risk factor. Number two, what's the second risk factor for this is trauma. So if you could imagine, if you don't have a good, strong erection, sometimes you miss the hole, even, during intercourse, you miss the hole, you hit some other part of the body. And as a result of that, your penis will bend, right? It'll buckle a little bit. And your body responds with inflammation into that area, and that inflammation eventually becomes a plaque. So those are the two main risk factors. So we do know the plaque is collagen. So the treatment for this is collagenase, which is the enzyme that breaks up that collagen. It works great. It's minimally invasive. It's a small needle injection, as you can see here. So you have a curved erection because of that plaque. And it varies anywhere from 30 degrees to 90 degrees. It goes left, right, up, down. Sometimes there's a corkscrew to the penis, but it's very limiting in terms of intercourse. Guys aren't able to have good erections as a result of this. It's very limiting. So, as I mentioned, closer to 10 to 15%. But what do we do for this? 3 treatment options for Peyronie's disease: pills, pokes, procedures. Pills, obviously the least invasive. This is oral therapies. Things such as Viagra and Cialis help. There's some medications that we take that decrease the risk of more fibrosis coming. We've used these for decades with minimal efficacy. If anything, it delays the progression of the Peyronie's. It doesn't fix it, right? The other thing, before, about a decade ago, we were doing a lot of surgery on this. But before I get into the surgery, I want to talk about this new thing that we came out with, which is called Xiaflex. Now, what is Xiaflex? As I mentioned, it's collagenase. So it's a series of 8 injections over 6 months. You inject directly into the plaque. That plaque over those 6 months will slowly break, and that penis over time will slowly straighten out. It works great. We typically say you're going to have a 50 to 60% improvement in your curvature with each treatment cycle. So every 8 injections, you should have a 50 to 60% improvement. Patients do 2 rounds, sometimes 3 rounds. That really helps straighten out that penis. Now, you don't need a perfectly straight penis. No one really has a perfectly straight penis, but you just want it straight enough for it to be functional. And that's what Xiaflex does for you. And as I mentioned, the procedures are pretty morbid, as you could imagine. The ones we do are more commonly something called a penile plication. So if the penis is curved like this, what we do is we put sutures. These are the pills, I'm sorry. Like I said, it only works for about 10% of guys. Xiaflex, series of 8 injections over 6 months. So the placation surgery, as you can see here, you're basically putting sutures on the other side, on the opposite side of the erection. And in doing so, it straightens it out. However, as you can imagine, this causes significant penile shortening due to the fact that your length vector is going to be limited by that curvature. So if guys are okay with penile shortening, we do it. But this is with Xiaflex out. This is incredibly. It's less common. We rarely do these now because of Xiaflex. And then there's also something called a plaque excision and graft, which again is very morbid. What we do is we go there and we surgically remove that plaque. We put a piece of pericardium, which is a piece of your heart, or it's cadaveric pericardium. We put it on the penis in that area and close it up. But there's a high chance of erectile dysfunction as a result of this. The results, as you can imagine, before and then after. So finally, the fourth topic we're going to talk about is incontinence. What is incontinence? Or what causes incontinence? As we know, prostate cancer surgery is one of them. It's very common. Less so these days with robotic surgery. However, it's still there. Number one, radiation could potentially cause this as well, just given the proximity of that sphincter close to the prostate and where the prostate gets treatment. Conditions that cause this: diabetes, multiple sclerosis, Parkinson's disease, strokes, and as well as pelvic trauma. Any type of trauma in that area which could disrupt the nerves to the external sphincter. Now, what options do we have available? Obviously, again, we have a ton of options. We start at the least invasive, which is behavioral modifications, limiting your fluid intake, trying to modify that, Kegel exercises could help as well. But again, those only could do so much. When those are limited, we go slightly more invasive, something such as the male sling. I don't know if anyone's familiar with this, but essentially what the sling does is it helps support the urethra. It gives it enough. If you think of the urethra as a hose, right? The urethra where your urine comes out of through your penis, it's a hose. Think of when you have incontinence, imagine that hose on a piece of soft soil. When you put your foot on that soft soil, it's not going to really compress it enough for it to limit the amount of urine coming through. What the sling does, it's imagining putting a piece of concrete underneath that hose. So when you put your foot on it, you really limit the flow of urine through that, or the flow of fluid through that hose. So that's what the sling is. Essentially a hammock right underneath the urethra, gives it enough support, limits the outflow of urine through it. Now, the sling is for guys who generally have, wear one pad a day. However, some guys, their sphincters they're incredibly incontinent. So something that's better for them and a little bit more, it opens more doors for them, is something called the artificial urinary sphincter, similar to the penile prosthesis in terms of the reservoir and a pump. Rather than 2 cylinders in the penis, this one, there's a cuff that goes around the urethra. So patients will squeeze the pump, and as a result of that, fluid from the cuff goes into the reservoir, opening up that urethra, allowing good flow of urine. And over the course of 90 seconds, that urethra will close back up. This is great. This is the gold standard in terms of what we have. It's probably the best thing that we have. The companies that make this are actually developing, not just for this, but also for the penile prosthesis, a Bluetooth device. So what they're doing is they're eliminating, it's probably going to come out in the next 3 years. They're eliminating the pump. Rather, there's going to be a Bluetooth activated motor engine that obviously internalized, that you're going to be able to control it. So you're able to activate and deactivate your penis and your artificial urinary sphincter through your phone. And this should be out, like I said, anywhere in the next 3 to 5 years. It's a great thing. It limits incontinence episodes, and a lot of patients are very, very satisfied by this. That concludes my talk. There's a QR code here on the right. If you take a picture of it, you could save my information. My information will come up. You can save it into your phone. My contact information has my number. Feel free to reach out with any questions. But yeah, if you guys have any questions here tonight, I'm happy to answer them.
Okay, we're going to start with a question from Victor. Is it correct that prostate cancer cells produce more PSA than healthy cells? If one's T level is off at 150 to 250 and PSA goes up, should we assume that it's cancer related?
What was that second part? If someone's PSA goes up?
I'll read the question again. Is it correct that prostate cancer cells produce more PSA than healthy cells? If one's testosterone levels are at 150 to 250 and PSA goes up, should we assume that the increase in PSA is cancer related?
It's a great question. So to answer the first part of that question, yes, prostate cancer cells will produce more PSA than regular prostatic tissue. Yes. So anytime PSA goes up to 5, 6, 7, that's very rarely is a result of normal prostatic tissue, unless your prostate's massive. But for the most part, to answer that first part, yes. Regarding PSA and testosterone levels, so if you increase, right, if your testosterone levels at 150 and your PSA is 2, let's say you increase your testosterone levels to 500 and your PSA goes up to 4, right? At that point, there's a decision to make, right? What you could do is you could stay on your current testosterone regimen. You could trend your PSA at 3 months and 6 months just to check it. If your PSA is staying steady, it's unlikely to be prostate cancer. However, if your PSA continues to go up, yes, it could be that could be an indicator of prostate cancer. So cancer doesn't stay in its current form. What it does is it divides, it grows, right? That's the whole point with cancer. The cellular architecture is messed up to the point where they keep dividing. So as long as PSA is going up, then as long as PSA is staying steady, you're not going to have cancer. But if it goes up, yes, it's indicative of probably indicative of prostate cancer.
Do we have any other questions from anybody? You can type in your questions here or unmute yourself by pressing down on your space bar and you can ask the doctor directly.
Yeah, I got a question.
Go ahead.
Yeah. So you didn't talk too much about or at all about the using a vacuum pump for erections.
Yeah.
Your thoughts on that? And I also had a question. I've been using one, and I had a urine test recently, and I had blood found in my urine. Would that have caused that, to happen? Get some blood in urethra and cause it to be in your blood urine test, or?
Yes, definitely. It could be a cause of hematuria or blood in the urine, just because of the way in which the device sits around, the way it cuffs the urethra and the penis. Number one, number two, just that suctioning. The urethral mucosa is very, very gentle and very sensitive. So any type of pulling, any type of pressure in that area, even a small amount could cause these micro tears, which could put some urine in the blood in the urine. Absolutely. So one thing I would recommend is if you try stopping that for a few weeks and then recheck your urinalysis and see what it shows. Okay. Otherwise, I'm sure your urologist is well versed in this, but there's a hematuria workup or blood in the urine workup that they could do. Now, vacuum erection devices for erectile dysfunction. It's a good question. It's less commonly used today. However, it's definitely part of. It is definitely something that patients use. So the reasons why it's good is because it helps really give that stretch. So it does two things. Number one, it creates an erection and helps engorge the penis. But number two, if you put a penile ring on afterwards, it gives you a functional penis, a functional erection, something you could use. It's becoming less common these days, but yes, it's good, not great. That's what I would say. And I never really give it to patients by itself. I would always either give them oral therapies with that, injection therapies, gels, something in combination with the vacuum erection device.
Yeah, I mean, I was kind of using it more of kind of to exercise it, to get some oxygen in there, to kind of, that type of thing, therapy. So
yeah, that's a great idea. It's just getting that stretch.
Yeah.
Okay. It does work. It does work. Yeah.
All right. Thank you.
Okay. Sure. A question from Gary. I have lost vision in one eye. Does Cialis increase my risk of losing vision in the other eye? Also, if I take Cialis, will I also be able to have an orgasm? So, you know, it isn't just a question of having an erection. Will I have an orgasm? And I assume, Gary, we're talking here about, did you have a prostatectomy? I think I'll let you go ahead and answer.
Yeah.
Okay, you did. Okay.
Oh, so so it's a good question about Cialis. So it does. If you have a history, it depends what you lost your vision for, right? Or as a result of. So Cialis does cause some visual issues. Typically it's it causes issues with coloring. Some guys will see blue as a result of it. In terms of vision loss, no, it doesn't cause vision loss. However, having lost vision in one eye, I would consult an ophthalmologist prior to starting Cialis. I would say it's a good idea to at least see an ophthalmologist before starting Cialis or Viagra to make sure we're crossing every T and dotting every I. No, that's number one. Number two, regarding your orgasm, if anything, Cialis is going to enhance your orgasm. Anything that increases that penile rigidity will make that orgasm a lot stronger. As a result of the prostate cancer treatment, you're not going to ejaculate. Nothing's going to come out, but you will have a stronger orgasm. Reason being is this: think of your erection as guitar strings, right? The more taut they are, it's easier to fire them, right? When you string that guitar, when they're so super tight, it's very easy to fire those, to make the guitar strings hum or make a noise. So the stronger the erection, the more nerves there are that are activated, and as a result of that, your orgasm will be a lot stronger. So yeah, definitely, it will help it. It will help that orgasm, no question about it.
This is Frank.
Hey, Frank.
Dr. Justin, hi. I put a lot of questions in the chat box for you. I mean, it's like 6, 7, 8 of them as you were talking, and I don't know. I'm sorry if I should have put it for everyone, and Neil could have read them out. But do you see them, Dr. Justin?
Let me see
Your chat messages. I put a series of them. I was just writing them as you were speaking, and.
Oh, here we go. Oh yeah, here.
Oh gosh. Yeah.
All right, is it correct? I should.
Frank.
All right, here, Frank. Frank,
Yes.
here you go. Has the tendency of men going to a medical doctor remained the same at the age of 50 years old, or are men going to see a doctor more earlier in their lives? Are there side effects in using medications? So to answer that question, yes, I think younger generations of men are much more likely to see their physician. They're much more in tune with their health. If they're experiencing any form of erectile dysfunction, they're happy to see their doctor. I had 3 patients today who were 25 years old who had erectile dysfunction that came and saw their doctor. I think 40 years ago, that would have been a completely different story. So are there side effects in using medications to raise T levels on a daily basis? So the side effects, the main side effect associated with any of these testosterone medications, whether it's the daily, weekly, or monthly version or quarterly version, is you could get something called erythrocytosis, right? Where you increase red blood cells in your bloodstream. It could stimulate your bone. Testosterone could stimulate your bone marrow to increase red blood cells. What does that do? It could make your blood thicker, and like we said, could cause stroke and heart attack. How do you mitigate that? It's very easy. You just check blood work every 3 months, not just for your hormones, but for your blood counts. And if your blood counts are high, if your red blood cell counts are high, we just tell you, hey, listen, it's a good idea to go and donate blood, and that mitigates it, and you do great on it. So that's really the main risk associated with it. Are there more effective education among men preventing health issues so they don't die? Yeah, the best thing I would say is, obviously each one has its own risk. The best thing I would say is regular checkups with your doctor, right? Regular checkups at an early age, right? And I'm not saying go to your doctor at the age of 30, like 5 times a year. Annual visits with your physician at the age of 25, every year going forward. Just a simple visit, a 1-hour visit with them, just to make sure all your ducks are in a row. What sources of information, books, and magazines are reliable and educated men, parentheses like diabetes? That's a great question. That's a great question. That's a tough one, given the fact that we're at a point now where there's so much information on the internet, right? There's so much out there. What I would say is, I don't know one off the top of my head, but a scientific journal is probably the best and most validated, with minimal bias associated with it. That's what I would say. Something like along those lines that would help answer these questions. The next question is, where does a man learn the value of testosterone levels, like PSA levels? Any doctor will draw a blood test, and you'll learn your testosterone levels as well as your PSA levels. The next question is, when is the time in addressing prostate cancer to get a testosterone levels and addressing the condition and direction of treatment? So I like to tell patients, get a blood test, check your PSA at the age of 40, right? It's important to check a PSA at the age of 40, at least your first PSA, especially if you have a family history of prostate cancer, whether that's a brother, an uncle, a father, or a grandfather. Next question is, does a primary care doctor identify and direct patients to see specialists when the symptoms are obvious of men's issues, and which specialists do they refer to? So I hope primary care doctors refer you to men's health specialists or a urologist. But even some urologists aren't versed in dealing with some of these issues. So some of this is in your own hands as a patient, where you have to say, hey, listen, do you think it's a good idea that I get a referral to a urologist? I get a referral to a men's health specialist. Or sometimes you being and depending on your insurance, you could seek out that consultation yourself. You could see whoever you want to see. Last question, is the general PCP educated to identify helpful referrals to specialists in the area of men's health issues? Yes, they should have. Any general PCP should know who to refer to regarding these various issues, whether it's erectile dysfunction, low testosterone, Peyronie's disease, urinary incontinence, any of that. Yeah, absolutely. Great questions.
Thank you.
Sure.
I have a question. If I can give you a little bit of history. My name is Keith, and 21 years ago, I had my prostate removed, and my PSA started going up within a very short period of time, and they put me back in, gave me radiation. And just skipping forward, I started having some urinary incontinence, and they installed the AUS. And it was, probably maybe a little less than a year, all of a sudden I started pee and poop and poop and pee, and it developed a fistula. And I was told that because the urethra was weak from the radiation that caused it. And I was fortunate enough to have they were going to have surgery on me. And a former pastor of mine had a gift of healing, and I went to him, and within 2 days, I quit. The problem was resolved, but I'm still incontinent. Is there any hope for me, or do I just have to live with it?
Is the sphincter out? They removed the sphincter?
They just turned it off.
Oh, so you still have a sphincter in place? It's
in place, but they turned it off, and I don't want to start it up again to get another fistula.
Huh. Interesting. And when was that? When was this whole episode? How many years ago?
I turned the fistula off probably, I'm going to say about year and a half ago.
Okay. It's interesting. That's an interesting scenario. So one thing you could do is obviously you could reactivate the device to see how that, potentially, obviously I don't know exactly what happened or what they saw in surgery, but I will say
I didn't have surgery. I didn't.
Oh, the fistula just healed up on its own?
It was healed by the pastor that prayed for me.
I see. I got you. Given the fact that it's been a year and a half, maybe 2 years that you haven't had any, pee in your poop in your pee, that fistula probably has closed off. However, there's a couple things we could do here. Is number one, we could do some imaging studies to see what your urethra looks like. It's a simple study where we inject contrast into the urethra and we take x-rays of it just to see what the path of that urethra is, to see if there's any outpouchings, potential fistulas, Let's say there's nothing there. Let's say there's nothing there. Even though we could even take, so there's similar cases to this. What we do is we remove that AUS, and because your urethra is so long, we could put the cuff anywhere along the urethra. So if this area is raw and has weak tissue because of radiation, we can move to a different area and put that cuff, right? And we could look and see if there's healthier tissue. So yes, to answer your question, you have options, right? If you're experiencing incontinence now and it's bothersome, there's things we could do for you, for sure.
Question. I went through a radiation and had a Lupron for 2 years, and I'm just coming off of it. I'm a couple months off of it. Part of the reason for the Lupron was not the PSA has stayed low, but part of the reason for the Lupron was to kill any or starve out any cells that were cancer cells that were drifting in the bloodstream that might metastasize. If I was to take any of the remedies for low testosterone, would that increase the chances of the prostate cancer metastasizing someplace else?
Yeah, good question. So are you still on Lupron?
No, last injection, I was having injections every 3 months. Last injection was beginning of October. So,
okay. So you're not planning to get any more Lupron, right?
No more Lupron.
Oh, okay, cool. Yeah. So, well, first thing is you have to come off the Lupron, right? And the things, what you want to check, and see is if the PSA rises, where you want to see if the PSA stays stable. But the thing to remember is the Lupron, it's a temporary shutdown of your natural testosterone production. So a lot of guys, when they come off Lupron, when they're off of it, over the course of months, their testosterone levels will go back up to normal. Will go back up, again, like things just get re-stimulated. So do you need testosterone today, right now? Probably not. And the thing is, what I would preach to you is patience, in the sense that if you do those things we talked about, sleep well, exercise, eat right, weight loss, those types of things, that will naturally increase your testosterone production. And you may, like I said, you may not need anything. So if you get your testosterone levels up and your PSA stays the same, hey, you're in business. You're doing good. You're doing great. So I would practice patience on this one for now, and do those things we talked about.
Thank you.
Yeah, no problem.
Question from Douglas. What was the name of the gel drug?
Yeah, so the gel, it's called Bimix gel. It's through a compounding pharmacy that we work with. So Bimix gel.
So when you say compounding, this is not something that I can go into my Rite Aid with a script and buy.
No, you need a prescription for this. Yeah, you need a special prescription for it.
Hello, Neil.
Hello.
Yes, hi.
Hi, can I ask a question?
Yes, please do, doctor.
Hi, this is Chuck Metzger. I used to work with one of your buddies, Gary Leach, some ago.
Oh, nice. Yeah.
Hope he's still there.
Great. Yeah, he's there.
Yeah, he's a good guy. He really taught us a lot.
Yeah.
Thanks for a great talk. But urology, I retired in 12, so urology is changing a lot for the better. And that sounds good, especially for Peyronie's. I hadn't realized they had something new for that. I would like to warn you, though, as a veteran doctor, you use something on Bluetooth and you lose your telephone, your neighbors are going to have quite an advantage over you.
Yeah,
so
yeah.
I would watch out that Bluetooth action,
Yeah.
But anyways, I just want to tell you what a great talk, and we appreciate your taking the time to do all this.
Thank you.
Yeah, of course. Happy to. I hope everyone learned something.
Oh, absolutely.
Yeah, very much so.
Thank you.
Of course. And yeah, I mean, you guys have my contact information. So if you have any questions, feel free to reach out. I'm happy to further discuss, whether it's telemedicine or whatever it is. Happy to. Anything I can do to help out.
Certainly, I was surprised that increasing testosterone won't put us at greater risk if we have prostate cancer.
Yeah, so I mean, in the setting of prostate cancer, so they actually published something in I want to say it was July or August, out of UCI, at University of California, Irvine, close in here in Orange County, and they looked at patients. They gave it to I want to say it was close to like 80 or 100 patients. They gave testosterone to post prostatectomy patients who had proven prostate cancer, and they did great. They really did great, especially in terms of PSA recurrence, prostate cancer recurrence. Really, the numbers were pretty impressive. Now, has it completely changed the paradigm in terms of everyone giving testosterone to prostate cancer patients? No, that's going to take time. But it does. There is a role for this. There is a role. Even more interesting, at MD Anderson in Houston, they're giving, for metastatic prostate cancer patients, they're giving high doses of testosterone periodically. And what they found is, by doing that, you're stimulating the immune system, and by stimulating the immune system, you're fighting those cancer cells. So they've had positive. Yeah, I mean, it's a clinical study. It's a clinical study, but that's what they found, early on. So far, that's what they found. Yeah, testosterone is so important. I can't stress it enough. It's so important.
Does anyone else have a question about testosterone? Because since so many of us are on castrate therapy, I have a question here from Douglas. Could you please summarize and describe the changes that I will have if I take testosterone?
Yeah. So that's a tough question to answer, because everyone's response to low testosterone is different. So some guys will respond to low testosterone by, they're completely fine, except they just have a low libido. Or some guys will respond, they're just not exercising the way you used to. So the question is, what are your low testosterone symptoms? And I would say that more than likely, if you have one of those low testosterone symptoms, by getting you back to a normal testosterone level, we should address that and get you back to normal in regards to that particular symptom. Yeah, but it varies from person to person.
Okay. No, I was just fascinated, because so many of us are on castrate therapy in this group. And you say, well, it's stimulating the immune system. That was a shocker.
I'm happy. I'll send you that article. I could email it. The article, just so you guys take a look at it. It's fascinating stuff.
I'll put it up on the next newsletter.
Yeah. Oh, here.
I'll send it to you, doctor, as soon as I get it at the prostateforumoc@gmail.com email.
Yeah, I have it here.
Fascinating.
So someone's asking I end the screen sharing so we can see the folks. How do I? Oh, here. There you go. Can everyone see now?
Well, I think we've got another question from Douglas. So are you saying that the testosterone can increase my libido? Absolutely.
If you have low libido, and we check your testosterone levels, and you do have low testosterone, absolutely. Testosterone should increase your libido. Yeah.
If you have prostate cancer and you're trying to keep the cancer at bay, there's a trade-off, right?
Yeah. So if you have prostate cancer, right? If you have prostate cancer and you're on Lupron, right? Taking testosterone, being on testosterone is not, right now it's not a good idea, right? We wouldn't put you on some form of testosterone replacement therapy while you're on Lupron, right? Because you're still in the treatment phase. Now, once you come off that treatment phase of Lupron and you finish your course of radiation, if your PSA is staying steady, then yeah, you have to wait 3 to 6 months. If your PSA is staying steady, hey, you could be a candidate for testosterone replacement therapy, but it's not for patients who are currently in that active treatment of Lupron, and we'd have to wait.
And if somebody's been on Lupron for a while, 3 to 6 months may be the minimum for testosterone to begin to recover, right?
Yeah, exactly.
Your suggestion of patience is probably a good thing.
Yeah. And but there's things you could do, right? There's things you could do to increase your testosterone levels naturally. The other thing I forgot to mention is, when it comes to exercise, cardio is obviously good for overall health. but it's weightlifting, right? And it's the big muscle groups. If you do squats, deadlifts, it's the quads, the hamstrings, and the back. Those, the more you do that, the faster your testosterone levels will go up. So if weightlifting, we're doing pull-ups, again, squats, deadlifts, that really helps.
I got a question on the testosterone medication. I guess you wouldn't recommend over the counter for the stuff that's being advertised on commercial.
Yeah, like the testosterone boosters. So
Yeah.
what those do is, typically what they have is they have a few things in them. They have zinc. We know zinc is it's a component that goes into testosterone production. You need a couple things for testosterone. You need magnesium, you need zinc, you need cholesterol, various coenzymes. Fish oil typically helps too. But those boosters, all they're giving you is they're just giving you supplements. Those the magnesium, the zincs, the other coenzymes that could potentially help with increasing your testosterone levels. To what extent does it help? I mean, you can never discount the placebo effect, but it's not gonna give you a noticeable or significantly noticeable long-term improvement. I will say that. It may last for a short period of time, but it's not long-term.
Does anyone else have a question that they'd like to ask?
Oh, someone asked, where's the study on metastatic castrate and the value of testosterone? So that was MD Anderson in Houston. The thing is, this is I don't know if they've published anything on it quite yet, because this is, we have friends, or I have friends who are running the study over there. So this is all anecdotal. So I don't know if it's out, if anything's published on there. So sorry, we'd have to wait.
Okay. Yeah. There seems, I mean, we're bombarded with these commercials, especially in the wee small hours of the morning. I mean, they've become infomercials for these various testosterone potions and notions. And I haven't talked to a urologist yet that recommended them.
Yeah. They don't do much.
I've got another question here from Steve. I'm going to try to pronounce the name of this medication. Sildenafil, safe to take. Silendafil, safe to take.
Yeah, so that's Viagra, and the question, that's the generic form of Viagra. So the answer is yes, it's safe to take, absolutely. Well, I will say the only the caveat to that is it's safe to take for all patients except for patients who are on nitrates for chest pain. If you're on that, I'd consult a cardiologist, or more than likely there's other options out there for you rather than the sildenafil.
Does anyone else want to add anything? Comment?
One other question. If patients have not been doing a lot of penile exercise and have been on a year or 2 years of ADT and get an intermittent break, say, and they've had some atrophy and are not getting full erections when it recovers, is there evidence that the vibration, the ultrasonic, other things are actually effective in restoring function if there's been a year or two of kind of not using it and losing it?
Yeah, great question. So if you don't use it, you lose it idea, I 100% agree. The penis is like that. If you're not getting good blood flow to it, it gets fibrotic, it shrinks in size, it shrinks in girth. That is a known phenomenon, right? We know that. Now, what can we do for that? I've established a penile rehabilitation regimen, which is very straightforward. It's very basic. It's basically daily Cialis and the vacuum erection device. The Cialis helps increase blood flow, so we decrease the fibrosis, and then the vacuum erection device really helps stretch it out. So, even though you're a year or two out, I would say it's not too late to start that. You could call my office. I'm happy to coordinate this with you and kind of give you the steps on how to do that. you don't even, we could do telemedicine or whatever, but I'm happy to help you because I think there's certain things we could do for you to at least bring some life back to it and minimize the that shrinkage and the fibrosis.
Okay.
I'm happy to help out. Yeah.
Anyone else have a question?
Yeah, can shockwave therapy be helpful for venous leak ED following prostatectomy? ED prior to prostatectomy was satisfied to address venous leak. Yeah. So, so I'm sorry. Let me read the question. Can shockwave therapy be helpful for venous leak erectile dysfunction following a prostatectomy? Erectile dysfunction prior to radical prostatectomy was satisfactorily addressed with Cialis. So, what is venous leak? So venous leak, as we discussed, to have an erection, you need good blood flow in, but more importantly, that blood has to stay in. So the veins that drain the blood from the penis have to be compressed, right? What happens is sometimes those veins aren't compressed the way they're supposed to. So you get something called venous leak, where you have no problem attaining erection, but you have a problem maintaining. Now, can shockwave therapy, so before I say that, we don't have any solutions for venous leak. We haven't figured it out yet, right? We don't know how to address it very well. But one thing that we could do for it is increase blood flow to the penis, right? Give you a stronger arterial inflow, and that could sometimes decrease that venous leak. So can shockwave therapy be helpful? Yes, definitely, it could help. To what extent, I don't know. We're still trying to figure that out just because it's a new therapy. But because it's increasing blood flow to the penis, because it's creating that new blood vessel growth, it can help in restoring blood flow and, like I said, decrease that venous leak.
Okay. Do we have any other questions? Remember to unmute yourself by pressing the space bar if you have questions. I think I'll take a little time to introduce our directors and advisors here tonight. At the controls is Dave Lehman, who is both our Chief Financial and Chief Technical Officer. Make sure that we're running with, among other things, Zoom and constant contact and our website, as well as maintaining our financial health. I see Frankie here. Frankie is our secretary, taking notes at our meeting and getting out communications. Maury Hartman helps with our hotline and our advanced diagnosis sharing group. Let's see, Jim Bothwell's here. Jim Bothwell is our treasurer. And we thank you, Jim, at this very busy time of year when we are processing your donations. And I'm Neil Burke. I'm both Chief Executive Officer and Vice President of External Affairs, which includes and not limited to outreach. So thank you, gentlemen, for being here tonight.
Neil, did you want to give a preview of Dr. Lamb?
Oh, I sure do. Next month, the 25th of March, we're going to be delving into genetics and the role genetics play in prostate cancer. This is something that's been emerging now the last year or two. We're seeing more and more of this, more and more discussion about the role of genetic testing in diagnosis and treatment of prostate cancer. Many of you know Dr. Richard Lamb of Prostate Oncology Specialists. He will be joining us again next month and help with a critical question such as, do I need a biopsy? Can my cancer be safely watched? Am I a good candidate for active surveillance? And of course, is prostate cancer hereditary, which is a controversial area. So join us again, 7 p.m. Pacific Daylight Time on March 25th for this very interesting, very exciting presentation. I can come back to questions. Does anybody have any other questions? Remember to unmute yourself by pressing a space bar. Doctor, is there anything you'd like to say in closing?
If you have any questions, as you know, I have that. I'll share my information again. as well as that scientific article. But if you guys have any questions, feel free to reach out. And I'm happy to answer anything down the road. But it was a pleasure talking to you guys. Thank you for taking the time. And I hope to see you guys soon.
Thank you, Dr. Justin.
Absolutely. Thank you. Thank you for the time.
All right.
And we look forward to having you
Appreciate
back
you.
again.
Absolutely. Absolutely.
In the meantime,
Have a great night, everybody.
Good
Thank you,
night.
you
We
too.
look forward to seeing you on the 25th of March.
Okay.
Have a good
Take
evening.
care.
All
Take care.
right. Thank you.
Bye.
Bye-bye.
Signing out.
Okay, buddy.